Thank you, Dr. Ganekar, for your kind words. My respected seniors in the audience and dear friends, many in the audience must be wondering as to what do we talk about. My previous speaker has set the stage by categorizing the young onset diabetes. So what new is there in this one? Do we talk about stem cells? Do we talk about the recent development in pumps and so on and so forth? Actually, we're going a little bit away from it. We'll not be talking about the pathophysiology, we'll not be talking about the insulin, we'll not be talking about the various pharmacological agents that are there, or even the diet. As clinicians, we are so engrossed with pharmacotherapy that we tend to ignore the elephant in the room. In what way? The title of the talk is Management of Young Diabetes Patient. And if you are careful, the most important word in that statement is young. Most of us tend to believe that youth is a smaller edition of adult. But that's far away from the truth, in the sense that they differ not only biologically but psychologically away from most of the adults. If we talk about the peculiarity of young diabetes, we'll see that physically they have a small body size, a rapid growth, progress in developmental milestones, etc. And that puts you in a different impact so far as the insulin dosage and close follow-up and the adjustment of the dosage. Behavior-wise, very importantly, they have got erratic eating behavior, altered sleep pattern, which all have got a very important implication so far as the management and the outcome of it in managing diabetes. Their insulin dosing needs to be altered. The risk of insulin stacking because of too frequent insulin dosing, inconsistency of meal timing. Morally, there is judgment based on personal preference, because as young they are much more judgmental than we are, and that makes a little bit of difficulty in cooperation with treatment. Emotionally, they are certainly different in the sense that they have got a high sense of self, and cognition and comprehension are also a little different. Socially, they are totally different compared to an adult. So an approach to an adult for diabetes treatment cannot be, just be multiplied over there as a young individual with diabetes. The roles and responsibilities, the incentive concept of an youth is completely different. They need an immediate incentive expectation, which because of their immaturity, they are not in a position to appreciate the effect of the treatment, and therefore it becomes all the more difficult to implement whatever that we know. We are not lacking the modality of treatment. We are lacking in implementation of that modality, and that makes all the more difficult. Whatever we have, whatever pharmacological agent or the way that we treat is enough to manage a person with diabetes, be it young or adult. But in young, because of the difficulty in implementation, it is little wonder that their average glycated hemoglobin hovers around 9.0. And your usual paper prescription will be as useless as a chocolate teapot. You know, that will not be implemented. So you really need to think out of the box how to treat young onset diabetes. These are the, advocated 10 P's that you need to think of the special needs so far as young diabetes is concerned. We need to think seriously about the person with diabetes. We also have to think that there is another couple of persons, maybe, as carer, who are also important in implementation of your treatment protocol. Partnership with the healthcare team is very important. Participation in the individual in the self-management, which is with time will be very important as they grow up. There is a role of professional training. it is very important that we think about the planning of transition and transfer in the process of transition. So far when they grow up, they gradually grow, the transition also need to be very important. The place identified for the clinic care also probably has got a bit of an bearing so far as the outcome of the treatment is concerned in this group of people with diabetes. We, of course, need to think about the effective input to pumps, which has been found to be extremely helpful in managing type 1 diabetes in youth. And we must not forget, especially when we are talking about we care in a Women's Day, about pregnancy, very important, and other pre-existing conditions. So we'll have to think about these 10 P's to talk about the best care output so far as youth onset diabetes is concerned, be it type 1 or type 2. So we need to focus specifically on patient-centered care. As I have said, that this is something extremely important, which may not be as important in an adult as in a child. We have to think of a special situation in school. How do they go? How do they complete their school curriculum? What about their extracurricular activities? What about sports activities? When they fall ill, what about the sick day rules in the school? How do you communicate with the school authorities to get the best out of the situation? Whether they need special permission to use insulin as well as special meal timings during school hours. So all these are very, very important in managing type 1 or type 2 patients in this particular age group. Needless to mention that they also need to have some special care in their jobs, which in our country we are not mature enough to wake up to the situation and give us some special privilege to those persons who are having type 1 or type 2 diabetes, just entering into job. And social and extracurricular activities should be as normal as in his or her peers. So these definitely needs to be taken care of. The challenges for a physician or a carer or a clinician is that we really do not have any toolkit available for any organization or society. You do have a lot of toolkit for CGMS, a lot of toolkit for, say, insulin pumps, but you really do not have any toolkit for implementation of your thoughts or implementation of your treatment protocol for people with type 2 diabetes or type 1 diabetes in the youth. Unfortunately, there are not many randomized trials of education and support programs for youth with type 2 diabetes, and therefore we cannot with sufficient confidence say that this is more useful and this is less useful. And in an era of evidence-based medicine, in an era of randomized controlled trial, we cannot really say that this is good or this is better. And needless to mention, patient-centered care is all about respect and empathy. When the patients are treated like they can be entrusted with big decisions about their own care, this is very important when a kid is treated. They should be given due importance. Their choices should be given due importance. And so that they can take big decisions about their self, it can empower them to care for their whole self and their mental health and stresses and goals. It may not be completely impertinent if I say that the Children's Hospital in Los Angeles have used a tagline saying that for young adults with diabetes, a dose of empathy is as important as insulin. A very bold statement. We know how to treat. There's nothing much to talk about really. The ADA Standards of Medical Care Diabetes has advocated, this is the latest one. The 2023 is following this on this 2022 in children and adolescents. If is based primarily on the glycated hemoglobin, if it is less than 8.5 or more than 8.5, or if they have got acidosis or decay or honk. If they have got less than 8.5, you start with metformin twice daily or whatever that you think appropriate. If the A1C is more than 8.5, you start with basal insulin and metformin and add whatever insulin that is needed. If somebody is having an acidosis, evident acidosis or decay or Hong, obviously the only choice that you rest upon is insulin, various types of insulin, various modalities of insulin that you know of. At the same time, we must also do the pancreatic autoantibodies. I mean, most of us do. At least a majority of endocrinologists practicing in the cities do have access to this this protocol of pancreatic autoantibodies. If they're negative, you go about with your A1C goals, with metformin and etc. If it is positive, then probably you'll have to think that here many people may need insulin as part of the treatment. Now this, I'll spend about 2 minutes. This is the ADA standards of care, quoted from ADA standards of care of all the medications. If I blow it up into 2 parts, you'll see you have got most of the medications that you use in the adults. But there are some few exceptions. I mean, these are recommendations for which you have got sufficient degree of evidence. I'll try to focus your attention on sulfonylureas. You have got glipizide, glimepiride. Glipizide is glibenclamide in our country. So you have got glipizide, glimepiride and glibenclamide, but there's no mention of gliclazide. Remember, in ADA recommendation there is no mention of the gliclazide. So if you have to use gliclazide, you do it at your own peril. Meglitinides, you have got repaglinide and ateglinides, fine. Alpha glucosidase inhibitors, you have got acarbose and meglitol, no mention of voglibose. So you really do not know whether you can use, which probably is the most used alpha glucosidase inhibitors in the country. So in adults we use voglibose, in youth probably we can't or we shouldn't. It's simply because of lack of evidence. That really doesn't mean that they are not effective or safe enough. GLP-1 agonist, all are available in adults and can be used in kids. DPP-4 inhibitors, you have got saxagliptin, sitagliptin, alogliptin and linagliptin, but there's no mention of vildagliptin. So what you do about vildagliptin is your own choice. Amylin analog, not much favored in our country. Thiazolidinediones, rosiglitazone and pioglitazone. Remember, rosiglitazone is advocated in addition to the pioglitazone that we use in adults and children alike. SGLT2 inhibitors, you have got sufficient evidence in favor of canagliflozin, dapagliflozin, empagliflozin, ortigliflozin, but not any other flozin like remogliflozin. Bile acid sequestrin and dopamine agonists are also known. So there is a bit of a difference so far as pharmacological agent is concerned. So that's all about pharmacology. Now what about anything else? Do we need to go for something else? Probably we should, because type 2 diabetes or type 1 diabetes in youth comes with a significant degree of mental stress. Does de-stressing improve the scenario? Do you have any evidence? It's an old evidence. Just because we do not have enough of data, enough of randomized controlled trial, it's a meta-analysis. And this meta-analysis says that de-stressing, psychological intervention for distress, favors your therapy. Now, how does it benefit the A1C? Does it improve this de-stressing or putting them on cognitive behavioral therapy? Does it improve in the glycemic scenario? We really do not know. The same old study had said that yes, it does improve on the glycated hemoglobin. But unfortunately, the recent one published involving more recent study had said that it probably does not. So psychological intervention may not be very important in improving the glycemic scenario, but they of course do have the importance in getting the patient in your favor by de-stressing him or her. So in summary, of course, one size doesn't fit all. The one which fits the adult may not be appropriate for kids. Empathetic approach is the principal driver for success. I cannot overestimate this one. Appropriate adjustments for pharmacotherapy based on approval status. Important that we should keep ourselves abreast in the field, that whatever is being advocated, whatever has got sufficient evidence in children, whatever is advocated by authorities or organizations across the world. Must not forget that parents are very important part of the partnership, and gradual empowerment of the patient would be key to success. So I'll put forward my happy Holi to all of you in the ensuing uh, next week, and we'll stop here and wait for your questions. Thank you very much.